Good afternoon, everyone. Thank you for joining me today. I would like to express my gratitude to the organizers of WCN for this opportunity to present today. I am Curie Ahn, and I am a nephrologist from Korea. Today, I will be discussing the overview of transplantation activities in Asia. I have no conflict of interest to disclose. As the General Secretary of the Asian Society of Transplantation, I have been working with several organizations related to transplantation. My presentations will be divided into 5 parts listed here. The 2021 regional data from GODT, which is classified by the WHO, showed that all the 3 Asian regions, Eastern Mediterranean, Southeast Asia, and Western Pacific, have significantly lower total transplantation activity rates compared to the American and European region. In this figure, we used the GODT data from 2019 to 2021 to exclude the impact of COVID-19. Out of 60 Asian countries, 25 submitted data during this period, while more than 7 of the 35 countries that did not submit the data had organ transplantation activity. According to the figure, only 1 country from the Eastern Mediterranean region, none from the Southeast Asian region, and 3 countries from the Western Pacific region had an activity of over than 30 PMP. Over the course of 3 years, the mean activity rates for total kidney transplantation in the 3 Asian regions were 11.7, 6.6, and 18.9 PMP respectively. These rates correspond to 42, 23, and 68% of the European rate. Specifically, DDKT rates accounted for only 14.2, 13.1, and 44.6% of the European rate. Thus, it is evident that the Asian regions have lower KT activity rate, particularly in DDKT, with the Southeast Asian region having the lowest activity. This slide presents data collected from the GODT between 2015 and 2021, taking into consideration the large number of countries with low frequencies, and it shows a significant difference in KT activity rates among Asian countries. Specifically, 36% of countries performed both LDKT and DDKT, while 12% only performed LDKT, and 7% did not perform any kidney transplantation at all. Additionally, 45% of countries did not submit any data during this period. Throughout this time, only 5 countries had average KT activity rates over 20.1 PMP, which is the mean value of global activity. Liver transplantation activity rates vary significantly among Asian countries too. The rate of LDKT is highest in the Western Pacific region compared to any other region. However, the total LT activity rates remains low in Eastern Mediterranean and Southeast Asian regions. According to the GODT country-specific data from 2015 to 2021 shows that the high LDLT rate in the Western Pacific region is mainly due to the particularly high rate of LDLT in South Korea. In fact, among Asian countries with total LT rates of 6.4 PMP, more, only 5 countries have comparable rates. When all organ transplantation data is plotted as a heat map, it confirms the significant variation that exists among Asian countries. Moreover, organ transplantation in the Asian regions is mainly performed as LDKT as opposed to disease organ transplantation. Thus, the characteristics learned from this first part of my presentation can be summarized as follows. A high level of clinical expertise that is not uniform across Asia. Less well-established programs for deceased donor organ transplantation. Both prevalence and incidence of ESRD indicated by the green bars are well known to be very high in the Asian regions. However, as mentioned earlier, the activity rate of organ transplantation in Asia remains very low. To analyze and improve this situation, a transplant database is needed. Since transplant databases have been reported for only 9 Asian countries, we established an online registry platform called the Asian Transplantation Registry ASTRAC in 2015. The ASTRAC provides a national and institutional database platform collecting and analyzing data across Asia. The ASTRAC-H is a kidney transplantation database platform that provides real-time data visualization and automated data verification for 227 variables. Currently, 9 transplantation specialists from 7 countries are participating in ASTRAC-H, and the data query process has been validated in 1,468 cases so far. With 81% of registered patients from South Asian region providing a valuable reflection of kidney transplantation in that region. The mean age of recipient is 42, which is significantly younger than the mean age of 51 for Korean recipients in country. Additionally, 62% of recipients in ASTRAC-H are male. The primary causes of kidney transplantation was glomerulonephritis, accounting for 53% of underlying diseases. The proportion of patients with diabetes and cardiovascular disease as comorbidities were very low at 17% and 1.5% respectively. About 8% of KT were from deceased donors. Most of the deceased donors were individuals who suffered from brain death due to traumatic injuries. CDC HLA cross-match tests for T and B cells were performed in 73% and 8% of cases respectively. HLA cross-match tests using flow cytometry for T and B cells were conducted in 19% and 5% of cases respectively. ASTRAC-H data showed 2 additional characteristics of Asian kidney transplantation. Firstly, the recipient populations are large and younger, with potentially preventable causes of kidney disease. Secondly, there is non-uniformity in the registries and the laboratory infrastructures across the regions. The health inequity in the field of organ transplantation, which was shown by earlier as one of the characteristics of Asia, has resulted in many Asian countries being listed in the country watch list of global organ trafficking. To address this issue, the WHO and the Transplantation Society declared the Madrid Resolution in 2010, which emphasized self-sufficiency. According to this declaration, a transparent and efficient governance structure must be established to optimize growth in organ donation and transplantation. The Madrid Resolution outlined three main areas of responsibility for nations to achieve self-sufficiency in organ donation and transplantation: enhancing organ availability, promoting fairness, justice, and transparency, and preventing the need for transplantation. As part of this global effort, the first VitalLink International Workshop was organized by VitalLink, a Korean NGO, and held in Seoul in 2011. In 2014, VitalLink organized the second VitalLink workshop entitled How to Achieve Self-Sufficiency in Organ Transplantation in Asia. The event brought together 30 representatives from 12 Asian countries and received strong support from the Transplantation Society and the WHO. At the workshop, the participants identified 6 action targets for achieving self-sufficiency in organ transplantation. These targets were prioritized based on their urgency and importance and included national policy, public awareness, networking, professional education, service resources, and the transplantation database. According to the data from the GODT activity survey conducted in 2020, it appears that many Asian countries have implemented essential elements for national organ transplantation programs such as deceased donor protocols and registries. However, out of 59 countries surveyed, 32 countries did not provide data. Among countries that did not provide the data represents by the gray areas in this slide may still face challenges in establishing organ transplantation system, particularly in the case of deceased donor organ transplantation. Establishing organ transplantation program in Asia low-middle income countries can be challenging due to the high cost involved in the process, while still adhering to the WHO and the Declaration of Istanbul's guiding principles of financial neutrality. Economic factors play a significant role, as evidenced by a strong positive correlation between total kidney transplantation activity rates and HDI index in both global with a correlation coefficient of 0.7 and in Asian regions with a correlation coefficient of 0.6. On the other hand, the fact that more than half of the reported total kidney transplantation activity rates in Asian countries are below the global mean trend line highlights there exist non-economic causes and room for improvement in transplantation system. Compared with LDKT, the DDKT graph on your right shows that as many as 24 out of 33 countries are located below the mean trend line of all countries. This finding indicates that there should be a reason other than economic reasons for the lack of activation of disease organ transplantation programs. When comparing the mean trend line of Asia in red and the global trend line in green in their relationship to Human Development Index, DDKT activity rates are particularly low in Asia. Based on this review, it is clear that there is an urgent need to establish a government-driven national organ transplantation system for deceased donor organ transplantation in many Asian countries. Building an integrated organ transplantation system in low-middle income countries in Asia is not an easy task, but it is not impossible. An example of this is Mongolia, where they have made significant progress in developing an efficient and transparent organ transplantation system with the government support and international collaboration. In 2007, I found Rafael International, an NGO dedicated to enhancing medical capacity in Asian countries. In 2010, I was working on chronic kidney disease project in Mongolia. In 2013, at the request of professors at the First Central Hospital of Mongolian Medical University in Mongolia, we held a small kidney transplantation seminar where we met passionate medical professionals interested in developing a transplantation program. Professor Jeremy Chapman attended the workshop as our advisor, as can be seen in this photo. After that, we began inviting young professors to Korea for a 3-month training program. Every year, we held clinical transplantation seminars and performed joint LDKT surgeries with the fellowship trainees at the First Central Hospital. In addition, we visited the Ministry of Health to explain the need for DDOT program in Mongolia. And we were able to hold a national conference on DDOT program development in collaboration with MOH and societal leaders, including Buddhist monks. We also initiated public discussion on disease organ donation through various media outlets and organized the annual Mongolian Donate Life campaign at the Skavatar Square in the center of the Ulaanbaatar city. In 2017, the Mongolian Rotary Club, one of the leading opinion groups in Mongolia, joined the movement of life sharing. We also started a lecture series on organ donation and transplantation at the medical college. In 2015, Mongolian professors organized the Mongolian Organ Transplantation Association and hosted the first International Congress of Organ Transplantation under the leadership of Professor Nyam Shiren. In 2015, the Regulatory Department of Cells, Tissue and Organ Transplantation, RDC-TOT, was established through the hard work of Professor Bachelon and his colleagues. And the disease organ donor identification and harvest workshop was also initiated. This Mongolia Vital Link program produced 93 fellows trained in the field of disease donor organ transplantation. The hard work of our Mongolian friends made it possible to establish a successful and This is the donor organ transplantation program in Mongolia. Based on our experience in Mongolia, we continued to support development of organ transplantation programs in Asia. This program is currently being implemented in Myanmar and Bangladesh and other according to the needs of each country. Since we believe that working together in goodwill would eventually lead us to the better world. Thank you very much for your attention. And I would like to close my talk with thanking the organizers for this opportunity. And I would like to thank our VitalLink International team members, co-workers, and advisors, especially to Vivian and Sophia for preparing these slides. And all of you are here today. Thank you.